Alright, good morning everyone. Let us discuss one of the commonest retinal conditions that a specialist will encounter, and that is age-related macular degeneration. This lecture will be divided into two parts, so we'll have two separate lectures because the topic is a little complicated. In this lecture, we shall discuss the etiology, pathogenesis and the clinical features, and in the next video, we'll go to the investigations and the management of ARMD. First and foremost, ARMD is the most common cause of irreversible visual impairment in older adults. So what do I mean by impairment? What do I mean by blindness? What do I mean by legal blindness? So there are certain definitions and certain criteria. I've made a video on this topic. I'll leave a link at the top of the video. Just have a quick look over that so you'll understand what do I mean by visual impairment. The basic problem in ARMD is at the level of the photoreceptors, that is the rods and cones, the retinal pigment epithelium, which is the outermost layer of the retina in direct contact with the choroid, and the innermost layer of the choroid, the choriocapillaris. So the earliest histopathological change is at the level of Bruch's membrane. So where does this Bruch's membrane lie? It lies between the retinal pigment epithelium and the choriocapillaris. So it is an interface between the RPE and the choroid, with some layers of the Bruch's membrane formed by the retinal pigment epithelium and some layers by the choroid. So it is not an independent structure, it is a transition zone between the RPE and the choroid. Classically, ARMD is divided into two types. There is a dry ARMD, where it is called dry because there is no formation of new blood vessels, and exactly opposite is a wet ARMD, in which case there is neovascularization. So invariably, ARMD will almost always begin as a dry case of ARMD, which can progress into two outcomes. Either it can lead to a geographic atrophy, which is basically a very widespread dry ARMD. So ARMD usually begins as a focal disease, but it becomes very widespread. It involves a lot of area of the retina. Then such a condition will be called a geographic atrophy. Or the second thing that can happen is neovascularization can come in. So a case of dry ARMD can become wet ARMD. It is very rare for the initial presentation to be of wet ARMD. If you catch a patient of ARMD at the beginning, it is most likely to be of the dry variety. ARMD is more common in developed countries as compared to developing, and that is simply because developing countries are still struggling with conditions such as cataracts, such as trachoma, such as refractive errors, whereas developed countries have gone beyond all those problems, and now these are all ARMD can be called a rich person's disease because only a rich person would notice it. And even anyone from a developing country is likely to present to you with a cataract first as compared to ARMD because that is more prevalent, that is more undertreated. Whereas a developed country will show more incidence of diseases such as ARMD, such as diabetic retinopathy. So diseases where the longevity is expected to be long. 8.7% of all the blindness in the world is attributable to ARMD, which roughly translates to 15 million population. Less than 55 years of age, very rare because it is called age related, so there needs to be a particular age that the patient needs to be crossed, whereas more than 75 years of age, it is incredibly common. The most common type of ARMD is dry. Thankfully it is dry because that is less severe, but the most severe variety is wet ARMD, and in between these two will be the geographic atrophy. The first most common cause of ARMD which produces vision loss is neovascularization, that is wet ARMD, and the second most common is geographic atrophy. However, do understand that the incidence of geographic atrophy is slowly increasing simply because we now have effective treatment for wet ARMD. We have anti-VEGF injections, which we'll speak in the treatment part, which allows us to sort of control the wet ARMD better. But unfortunately, dry ARMD, the most common type, still does not have an effective treatment. Also, patients of ARMD are living longer because of other reasons, because of better nutrition, better health care, better vaccination. So as the patient lives longer, this dry ARMD is going to get converted to a geographic atrophy. So the incidence of geographic atrophy is slightly going up, but however at this point it is still wet ARMD that is the most severe type of age-related macular degeneration. I want you to focus on this image. This Bruch's membrane is at the core of pathogenesis of ARMD. Bruch's membrane lies between the two green lines as you can see in the image. It is made up of 5 layers. The innermost layer is the outermost layer of the RPE, and the outermost layer of the Bruch's membrane is the innermost layer of the choroid. So this image will make it very easy to understand. So Brooks layer is the interface between the retinal pigment epithelium and the choriocapillaris. If you want to understand the layers of the retina in a little more detail, I've made a video on that. Click on the link at the top of the video. That should help you out. So let's proceed. So Brooks membrane is at the center of the pathogenesis of ARMD. So what exactly goes wrong? Any individual when aging loses some of the body functions. So the RPE is no different. The function of the RPE is to maintain metabolism of the retina, to transport and diffuse nutrients across the Brooks membrane between the choroid and the retina. So with an age, this RPE function is failing. So there is a functiolasa, a loss of function. Consequently, there is a lot of waste material accumulation in the Brooks membrane because of an inadequate metabolic exchange. So more specifically, lipids start accumulating in the Brooks membrane, and when lipids accumulate in the Brooks membrane, that appearance is called a drusen. So a collection of lipid is called drusen, which happens in the Brooks membrane. This is a PAS, periodic acid shift positive structure, and this is the earliest visible sign. Drusen is the earliest visible sign in a case of ARMD. Continuing with drusen, it constitutes mainly of lipids, but that is not the only constituent. There is amyloid and complement factors. More specifically, complement factor C3A, which means an activated complement, and a C5A, which also is an activated complement. So now when there is going to be so much deposition in the Brooks membrane, there are going to be changes that you see in the Brooks membrane. There is going to be thickening naturally because there is a deposition of external material or deposition of foreign material. There will be degeneration because this deposit will interfere with its functioning. Dystrophic calcification will also occur as a consequence of the degeneration. AGE accumulation means advanced glycation end products, more commonly seen in diabetics. AGE pathogenesis is more important in case of a diabetic retinopathy as compared to ARMD. However, it also plays a role in case the patient is diabetic. And finally, there can also be an abnormal protein accumulation in the Brooks membrane. So what this deposition on the Brooks membrane does is it cuts off the communication between the retina and the choroid. When I say retina, I mean the retinal pigment epithelium, and when I say choroid, I mean the choriocapillaris. So there is a hydrophobic barrier that forms. It does not allow the diffusion of water and other substances across the Brooks membrane freely. Consequently, the retina undergoes a relative ischemia because understand, the outer layers of the retina receive their blood supply by diffusion through the choroid. So when this barrier happens, there is a relative ischemia. The blood supply is cut off. Consequently, wherever there is ischemia in the body tries to increase the blood supply by producing neovascularization. So most commonly, this neovascularization happens from the choroid into the retina through a damaged Brooks membrane. So it is the choroidal vessels that are trying to make up for the tissue ischemia. It is very rare that new blood vessels are formed within the retina. So more commonly, it is the choroidal blood vessels growing into the retina through a damaged Brooks membrane. A quick look at the genetics of ARMD. A very important genetic component is labeled to ARMD. So it is not all external. Sometimes it is also internal. Many a times it is internal. So clinical features correlate between monozygotic twins of the same age in almost 100% of the cases. Whereas if the twins are dizygotic, then almost 50% of the cases, 50% pairs will show similar clinical features of ARMD. What exactly am I pointing at genetics? What is going wrong in the genetics of the patient? It is the complement pathway that is at fault. It is an abnormally active complement pathway that is producing inflammation. So which are the factors? There is complement factor H, HTRA1, complement factor B, C2 and C3. So the last ARMS2 is not actually a complement, it is just a gene that is seen to be dysregulated in a case of ARMD, and that is present on chromosome 10. The presence of an abnormal complement factor H predisposes you to a bilateral geographic atrophy, whereas a presence of an abnormal HTRA1 predisposes you to a bilateral choroidal neovascularization. When I say choroidal neovascularization, I mean neovascularization only. There is no different. It is just labeled as choroidal to make it more clear that the origin of the blood vessels is from the choroid itself and not from the retina. And an abnormal C3 predisposes you to having a geographic atrophy more than a choroidal neovascularization. So certain predisposing factors and their associated complement factors are labeled in the table as shown below. So what risk factors am I talking about? First and foremost is genetics. that is very easy to blame. It is your genetics that is causing ARMD, and previously it was considered to be a non-modifiable risk factor simply because we thought that we cannot touch genetics as of now. You cannot do anything if the genes are at fault. However, right now we have targeted gene therapies that are under trial, so maybe in the near future genetics becomes a modifiable risk factor. Smoking increases the risk by 2 times. Obesity, which is associated with atherosclerosis and an inappropriate diet. Sunlight is said to be a predisposing factor. So the basic pathology is that enough damage to the RPE can be created if you stimulate the RPE enough by sunlight. So phototoxicity, a mechanism of phototoxicity is suggested. So that produces an early degeneration of the RPE, and consequently the process of ARMD is sped up. Aspirin is said to be, an experimentally observed risk factor. So if a patient of ARMD requires some anticoagulants, a drug other than aspirin should be considered, probably clopidogrel or some other combination which does not include aspirin. Blue iris, so this is very interesting. This comes back to the phototoxicity principle. Brown iris has a higher melanin content compared to blue iris, so it will absorb more light energy, or the more of the photochemical energy, as compared to the blue iris. Blue iris will allow the light to go back and hit to the retina more often compared to a darker colored iris, because the melanin content is low, and consequently the process of phototoxicity is sped up in a patient who has a blue iris. So what clinical features should I look for? Let's divide them into dry and wet, because that forms the basis of our diagnosis, that forms the basis of the further investigations and treatment. So it is very important to determine whether this is a case of dry ARMD or a wet ARMD, and that is one of the first things that you will look for when you see a patient of ARMD. First clinical sign is a drusen. So a drusen will appear eosinophilic, which means it will appear pink on hematoxylin and eosin staining. It is a focal whitish or a yellow collection. Sometimes they are confluent, many a times they are separate dot-like appearance, and they are more common at the posterior pole as compared to the periphery. So when I say posterior pole, it means around the macula, and periphery means extramacular or extrafovea. Peripheral drusen are of no visual significance because there is a considerable overlap that occurs, so the patient barely notices any loss of vision. However, if it is at the macula, vision disturbance is early. And this drusen, the location of this drusen is between the RPE and the Bruch's membrane. It is at the interface of these two structures. Depending on the size, they are classified as a small, medium, or large. The small is less than 63 micrometers, medium is more than equal to 63, and less than 125 microns, and large is more than or equal to 125 microns. So it is not physically possible to measure these. These are experimentally found values. So how do I see clinically which is small, which is medium, and which is large? Because I'm talking about microns. So one easy way to correlate this is to look at the size of retinal vein at the optic disc margin. So the optic disc margin retinal vein has a diameter of 125 microns approximately, but it's in the range of 120 to 130. So 125 seems to be a safe approximation. So if you see a drusen that appears to be of the same size as the retinal vein at the optic disc, then that is likely to be of the size of 125 microns. So it will either be a medium or a large, depending on how large or small it appears in relation to the retinal vein. If it appears larger than this vein, then it is definitely large. If it is smaller, then a little bit of clinical judgment will be required to call it either small or medium. And as I've already mentioned, it is a periodic acid Schiff positive structure. There are two types of drusen. There is a hard drusen and a soft drusen, very similar to the hard exudate and soft exudate that we see in diabetic retinopathy. Hard drusens are round, whereas soft drusens are more confluent in appearance. Hard drusens are well-defined margins, that is why they are called hard, because they appear hard, whereas soft drusens appear very soft and ill-defined. Hard drusens usually small in size, whereas soft can be small or can be large, or can be medium or large. Any size is possible because now they become confluent, so it can take any size that is possible. Hard drusens are not age related, which means 80% of the population more than 30 years of age will show at least one hard drusen. So consequently, it is of no visual significance, whereas a soft drusen is more significant of a visual pathology, and it is an age-related condition such that 26% of the population more than 70 years of age will show at least one soft drusen. So when I see a drusen, it is not always problematic. It is not always, it does not always require treatment. So what are the characteristics which I should look for in a drusen, or which I should not, neglect? So it should, if it is soft, it is large, more than 5 drusen are present, confluence of drusen is seen, and RPE stippling. So RPE stippling is basically the image that is shown below. It is actually a fundus fluorescein angiography image. We'll discuss that as a part of the investigations in more detail. But just look at the dot-like appearance of the RPE. So that is called RPE stippling. And finally, if there is a family history of wet ARMD, or the other eye of the patient has a wet ARMD. So these are all high-risk characteristics of drusens which need to be looked for specifically. Now there is a phenomenon called reticular pseudodrusen. So this appears like a drusen but is not exactly a drusen. So this is basically a fibrous replacement of the choroid in a reticular appearance, in a sort of web-like appearance. So it is very often confused with a drusen, but you need to understand the basic levels, the layers at which the pathology is happening. A drusen occurs between the RPE and the Bruch's membrane, whereas a pseudodrusen occurs inside the choroidal stroma. One thing you have to understand, drusen alone do not cause severe vision loss. They will not make the patient finger counting 1 meter or 2 meter. They will perhaps bring the vision down to finger counting 6 meters, 660, 636. But there are associated symptoms that the patient can come to you with, which form the clinical features of dry ARMD. First and foremost is gradual painless diminution of vision, either unilaterally or bilaterally, depending on either eye is affected. But there are associated symptoms such as delayed light and dark adaptation. There is metamorphopsia, which means a distortion of the objects that you see, a loss of reading speed, which is due to the impaired contrast sensitivity that the patient has, and finally a central scotoma, so a blind spot at the center, simply because the macula is now affected. The second symptom that you can see is the second sign is a focal hyperpigmentation of the RPE. So the image that I show you below is not exactly of an ARMD, it is of some other condition, but just to give you an example of what hyperpigmentation means. So those black dots that you see, there is an increased pigmentation of the RPE in focal regions of the retina. And this hyperpigmentation increases if a drusen is already present. And if you see a hyperpigmentation, then the chances of progression of the disease even further increases. So a low grade can become a high grade more often in case of the presence of a hyperpigmentation. And finally, let's come to geographic atrophy now. The geographical atrophy is a very advanced dry ARMD. These are well-defined areas of hypo or depigmentation. So exactly opposite to the focal hyperpigmentation that we saw. So there is a loss of pigment from the RPE, usually less than 1 disc diopter in size. The appearance is usually petaloid around the fovea, which means like petals, it is spread out around the fovea. And if it is not around the fovea, then there is a constriction of the visual fields. Usually it follows the drusen. So if a drusen appears in a particular area of the retina and now starts regressing, now starts getting absorbed, then a geographical atrophy will start at that particular point itself. So this is an image of a geographic atrophy. Just note how there is a loss of pigmentation. You can see the yellow structure, a yellow appearance of the atrophic area. So it is more common at the macula. Now let's look at the clinical features of wet ARMD. First and foremost, neovascularization. This neovascularization happens within the macula, and there is an ingrowth from the choriocapillaris, which is also called a typical choroidal neovascularization. So the most common, where the choroid gives off new blood vessels into the retina, such a condition is called a typical choroidal neovascularization. Very rarely, the blood vessels arise within the retina. So such a condition will be called retinal angiomatous proliferation. Very rare, typical is much more common. So let us stick to that. The symptoms that wet ARMD can produce is a sudden diminution of vision. Until now, when we talk about dry ARMD, when we talk about geographic atrophy, the vision loss is gradual, progressive, whereas wet ARMD can cause a sudden diminution of vision. Because understand the neovascular vessels that form, they are very weak. They can rupture very easily, they can cause a hemorrhage very easily. So this hemorrhage can occlude the retinal structures and cause a sudden diminution of vision. There can be a subretinal fluid and intraretinal fluid. Hemorrhage can occur either in the subretinal or the intraretinal space. Lipid exudates can deposit because this again, if the neovascular vessels are weak, if they are very permeable, then all these lipids are going to leak out and form exudates. retinal pigment epithelium detachment can occur, retinal pigment epithelium tear can occur, and finally a cystoid macular edema can be seen. The end stage of neovascularization, either with or without treatment, can be a fibrovascular or an atrophic scar, because this neovascular blood vessels have a very high fibrovascular quantity and very little muscular properties. So a fibrovascular scar or an atrophic scar can be seen at the end of neovascularization. So the left hand side image shows you a choroidal neovascularization and the right side shows a retinal angiomatous proliferation. Very difficult to tell which is which only on ophthalmoscopy examination, but if you notice, choroidal neovascularization is much more dense in appearance. The RAP is a little, sort of sparse, and the blood vessels are also very thin appearing. Sometimes it is not possible to tell clinically. You will require additional imaging modalities, which we shall discuss as a part of the investigations. Second sign that you can see is the RPE detachment. I thought I should specifically mention about this. So RPE detachment is also sometimes written as PED, which is nothing but pigment epithelium detachment. So when I say the pigment epithelium is getting detached, it is assumed that it is the retinal pigment epithelium that is getting detached. That is why there is no need to write an RPED. A PED is sufficient. 4 things can cause a PED. Either there is a drusen deposit below the retinal pigment epithelium, a serous fluid collection, a fibrovascular proliferation, or a hemorrhage. So this again happens between the RPE and the Bruch's membrane. So any of these 4 depositions or conditions can lead to the RPE detaching from the underlying choroid. In addition to these signs, other age-related features can be seen. For example, the brow can undergo ptosis, the brow can droop, you can have an arcus senilis, you can see an immature senile cataract. So other features of age-related changes also need to be looked for. A clinical classification has been suggested for age-related macular degeneration. Very simple to understand. First and foremost, what you have to understand that this classification is based on 2 things, either the presence or absence of drusen, and finally pigmentary changes, if any. So a normal patient will not show drusens, will not show pigmentary changes. Age-related changes can be seen in the form of drusen. So remember, drusen needs to be medium or large to be considered pathological. Small drusens, also sometimes called drupelets, which are less than 63 microns, are very commonly seen in age-related conditions, not necessarily macular degeneration, whereas pigmentary changes are not to be seen. Early ARMD drusens will be medium in size, and intermediate ARMD they shall be large in size. Intermediate ARMD also shows pigmentary changes. Any sort of pigmentary change, either hyper or hypopigmentation, is acceptable, whereas late ARMD will show neovascularization and a geographic atrophy. So the last 3 columns talk about ARMD. That takes care of the lecture for today. We'll deal with investigations and the treatment of ARMD as a separate lecture. Thanks for watching. Stay safe, stay indoors. Subscribe to the channel if you like our method of teaching, and please do come up with suggestions. Thank you.